welcome to this Prostate Cancer Awareness event in Black History Month at the University of Hertfordshire. And what I'm going to do is I'm going to say a couple of housekeeping things to start off with, and then I will issue my welcomes. But the first thing I want to say is that because of another technical issue, this whole event will be recorded, and there will be a question and answer session right at the very end. If you want to ask a question and you want to do it anonymously, then send your question into Mr. Evans Bobo, EVANS, Evans. You'll see him come up, and you can send that privately, and you can ask a question through Evans if you prefer to do it that way. But otherwise, there will be 4 parts to this session. The first is my introductions and apologies. The second is with Mr. Nikhil Vasdev, who I hope you can see on screen at the moment. The third is with Professor Prokar Dasgupta, who's yet to join, but we hope we'll get there by that time. And the final section will be the question and answers. Now, what I'm going to do now is to just introduce the speakers, and I want to say in advance that normally I would be here in Black History Month talking about Black Delta blues music, so it's very different today. I want to talk today about prostate cancer. 1 in 4 black men will be affected by prostate cancer at some time in their lives, and not such a dissimilar figure, 1 in 8 white men will be affected. These are the Prostate Cancer UK figures. So this Black History Month session is really very important because this one can save lives. I'm going to do my introductions in reverse order, in true Miss World style. I know that's a bit old-fashioned, but first I want to thank Evans for being persistent as my right-hand person in helping to organise, advertise, manage, and with humour keep on with getting this right for us. But my real introductions are to 2 people who are not from the university, but are associated with the university. We're very fortunate to have 2 of the UK's leading cancer surgeons and researchers with us today. In the final part, it will be Professor Prokar Dasgupta, who is Professor of Surgery at Guy's Hospital, and he's a Fellow of King's College London. Now, he's a real pioneer of robotic surgery. He's been a prolific author as well, and he will be telling us about the latest research. But first on to talk about symptoms and treatment is Mr. Nikhil Vasdev. And Nikhil has performed well over 500 robotic surgery cases. I think he actually reached that landmark at the end of 2018. And amongst the number of plaudits, I'm just going to pick out a couple because I don't want to spend time on that, because what you can do is also then go on to look up more about Nikhil's profile. Just to say that he was the first nationally accredited fellow of robotic surgery from the Royal College of Surgeons. He regularly advises and he could probably give you a whole catalogue of his globe trotting, but I will pick a couple: Thailand, Belgium, Hong Kong, and even further afield, to initiate and lead on robotic surgery across the globe. But I am going to say, most fortunately for us, he is a consultant in Hertfordshire, working at the Lister and in Hitchin, and I'm enormously pleased that the University of Hertfordshire has been able to honour him with an honorary DSc just this year. But I'm going to say that I'm doubly grateful to him, not just for coming today, but I will tell you that on Tuesday the 4th of December 2018 at about 4 o'clock in the afternoon, we met for the first time. And it was when I was told that I had prostate cancer, and he took me into his room and told me the options and said, "You're doing the right thing." Well, must be true. I'm still here. almost 2 years later. And so I'm doubly grateful, and I'm absolutely delighted. And never thought I'd say this. I'm absolutely delighted to introduce my surgeon to you, Mr. Nikhil Vasdev, who will be telling you about symptoms and treatment. It's over to you.
Thank you very much, Peter. I'm just very grateful for your introduction, and it's an honor to know you too and look after you. So thank you so much for your very kind words. So I'm going to give two talks tonight. The first is to do with prostate cancer and the importance of prostate cancer awareness in the context of incidence, symptoms, and diagnosis. Now, this is a very important time. Obviously, the COVID-19 pandemic is ongoing, and there's certain important things that we've noticed with a slight decline in the number of patients coming forward with prostate cancer diagnosis. So we are going to propagate and work towards doing more and more communication and comms around encouraging men to come through. So prostate cancer is now the commonest cancer in the UK. And this has also overtaken tumor sites such as breast and ovarian cancer. And approximately year on year, we tend to see about 47,000 men diagnosed with prostate cancer, and be it in the context of early prostate cancer through to advanced disease. But not only amongst these 47,000 men, but the mortality of prostate cancer per year is about 11,000. So still there's a lot of research taking place, a lot of newer treatments coming out, which will hopefully benefit patients, especially in the context of advanced disease, that is disease which has gone beyond the prostate to lymph nodes and to bones. So overall, it accounts for approximately 26% of all new cancer cases in the UK. The peak age, based on demographics that we catch, is sort of after the age of 74 and 79. But with more and more prostate cancer awareness taking place, we are seeing younger patients come through with a prostate cancer diagnosis. Now let's talk about the prostate. What is the prostate? So the prostate is a walnut-sized gland, which is a part of the male reproductive system, and it is located below the urinary bladder in front of the rectum. The prostate makes some fluid that nourishes and protects sperm cells in the semen. But just behind the prostate is a gland called the seminal vesicle, where a lot of fluid, again, is produced to mature semen. And in the context of prostate cancer, when we stage patients, we not only look to see if the prostate cancer is confined to the prostate, but also to the tubes around the prostate called the seminal vesicles. And the water pipe, the urethra, passes through the prostate. This is called the prostatic urethra, which carries, obviously, urine and semen running through the prostate. Now, prostate can be impacted by a lot of different conditions, because as a man gets older, the prostate also grows in size. So the commonest sort of situation we tend to see as urologists is prostate enlargement, in which the prostate has grown big, which is causing some degree of obstruction to the voiding symptoms of men, which start coming about, in which patients notice that their flow is deteriorating or they're waking up more often at night. So this falls into the category of bladder symptoms or lower urinary tract symptoms. We also tend to see patients who have a degree of prostate inflammation, who might have waterwork infections. But obviously, tonight's talk is more focused on prostate cancer, which, as highlighted in the past few slides, is a common, if not the commonest tumor in the UK. Now, if you look at the entire population graphics, in the UK, 1 in 8 men will be diagnosed with prostate cancer in their lifetime. And it's also important to remember that a family history is important to corroborate when a diagnosis is being thought of or being established. But as Peter mentioned, Afro-Caribbean gentlemen or Black males have a chance of 1 in 4 men being diagnosed with prostate cancer, as against 1 in 8. And the age, as I mentioned, also was 74 to 79. This age group is now about 50. So younger men with a higher frequency in the Afro-Caribbean population. A very common symptom that I get asked is, what are the symptoms of prostate cancer? Most men do not have any symptoms. It is purely picked up either due to a combination of a digital rectal examination in the primary care sector, on the basis of a blood test called a PSA, and I'll share a few slides with you on what the PSA is. But the important factors which need to be considered are family history, the age of a patient, changes in waterwork symptoms, and obviously the ethnicity of males coming through. Afro-Caribbean patients have a higher chance of being diagnosed with prostate cancer. So let's look at some of the symptoms that have been documented, which have also been passed on in communications down to general practice. So change in waterwork symptoms could be down to needing to wee more often than usual, difficulties in straining to wee, a weak flow, feeling the fact that the bladder hasn't really emptied, but there's a lot of overlap of these symptoms largely down to benign, which is the non-cancerous enlargement of the prostate. Other symptoms may include blood in the urine or blood in the semen, lower back pain, especially if the prostate cancer has advanced and spread to the back, feeling tired in patients who have got disease which has gone beyond prostate, and even some patients may complain of a degree of erectile dysfunction, although this is not very specific, but we do tend to see this sometimes. And in advanced cases, obviously, patients will have symptoms of anorexia and weight loss. So let's focus our attention on Black men and prostate cancer. So data indicates that 1 in 4 men will get prostate cancer in their lifetime. That is in the Afro-Caribbean population, in comparison to 1 in 8. And if a gentleman is Afro-Caribbean, the question comes up is, what is the risk? When does the risk go up? So the risk proportionally goes up after the age of 45 or 50. And this is what's been noticed. And obviously, as patients get older, the chances of prostate cancer being diagnosed is higher. And if there's a strong family history, father or brother has had prostate cancer. And at Prostate Cancer UK, and I'm pleased to inform you that this event has been endorsed by Prostate Cancer UK tonight. They are doing a few research studies to evaluate why exactly the Afro-Caribbean population has a higher risk. So if you feel that you're at risk, you can log on to the Prostate Cancer website, and there's a questionnaire to complete in which we are also doing work to evaluate to see why this particular population of patients has a higher propensity of prostate cancer. Another important question to evaluate is, what should an Afro-Caribbean gentleman do over the age of 45? What are the next steps forward? So the options are, you go and see your GP, especially if you have a family history, and if you're Afro-Caribbean after the age of 50, or you can call your GP up and have a chat to go over the pros and cons of a PSA test, which I will discuss with you in the next few slides. Now, the PSA stands for prostate specific antigen. It is a blood test, but it actually, in the context of physiology, is an enzyme which keeps the semen in a semi-liquid form in the prostate. Now, prostate-specific antigen can go up in numerous conditions, be it from the perspective of an enlarging prostate as men get older. Obviously, there's inflammation, there's an infection, the PSA may go right up and come down. But prostate cancer is also is when we tend to see it. Patients who have had intercourse or ejaculated may have an elevated PSA. A slight increase may take place once the patient has been examined, but with cycling and excessive exercising too, we can see a high PSA level. So when we see patients in the clinic with a slightly high PSA level, we exclude all these histories, sexual intercourse, a rectal examination, cycling, infection, before we take them down the route of being evaluated for suspected prostate cancer. Now, the advantages of a PSA blood test is obviously it's an invasive test. It involves a quick blood sample, which takes about 2 to 3 days to come back in normal context. And it can pick up symptoms of prostate cancer. Because the PSA corresponds to the degree of intensity of disease in a majority of patients, it may also pick up the difference between fast-growing and slow-growing tumors to help us predict how a tumor may behave. And having a regular PSA test, can identify patients who may get prostate cancer based on some data which has come out. But spot changes in PSA, so PSA alone is not a good enough way to evaluate patients. This has to be in the context of a clinical evaluation, a rectal examination, drawing out the profile of patients who have a risk for prostate cancer, and then evaluating them more in detail. So the advantage of PSA, yes, it's convenient, but the disadvantage is that it can also be up in a lot of other conditions which affect the prostate as against prostate cancer alone. So the disadvantages are that the prostate level may be, may be raised even if you don't have prostate cancer. It may miss prostate cancer purely on the basis of a blood test alone. And if the PSA is raised, you may need some invasive investigations doing. So it's important to put everything into perspective in the context of putting a patient through an invasive test such as a biopsy. In the UK right now, we do not have a screening program for prostate cancer. We do have screening programs which run for breast, cervical, and bowel cancer, but we hope that based on the amount of data coming through that a prostate cancer program may be put forward. The reason why we don't have a prostate cancer screening program is because of the statistics, which is number needed to treat. But again, like I said, there is work taking place to probably work towards having a selective screening program. And the reason for why we don't have a program right now is basically overdiagnosis and overtreatment, because certain patients may have prostate cancer which may not affect them at all. So it's all about having a balanced and risk approach working towards the establishment of a diagnosis of prostate cancer. So talking about the investigations, when we have a lot of people who are referred to us either from primary care with an elevated blood test or an abnormal digital rectal examination, or we also have patients who come through the emergency department with advanced prostate cancer. This is what we tend to see. So when a patient has got advanced disease, they may come into A&E with a blocked bladder or with cauda equina, which is when the disease has gone to the spine, leading on to paralysis. So in advanced disease, we tend to see this. But as far as we are concerned, when we see a patient with suspected prostate cancer, the first thing we do, of course, is a clinical review. We examine the prostate, and now what we tend to do is do an MRI scan of patients before a biopsy. And in certain situations, when we suspect advanced disease, we will do a bone scan or something called PET scans. And MRI is a very useful tool. It can help not only diagnose exactly where the anatomy of the tumor may be, but also in the context of what the tumor is doing from the functional point of view. We tend to score the abnormal features on an MRI from 1 to 5. This is the PIRAT score, which we pick up. And we're doing quite a lot of artificial intelligence trial work at the Lister Hospital in the University of Hertfordshire, looking into AI in prostate cancer diagnosis. But essentially, depending on the MRI, we give the MRI a score from 1 to 5, 1 being the chance of clinically significant cancer being highly unlikely, and 5 being a chance of the cancer being highly likely. So depending on what the MRI shows, we will then put a patient through now a local anesthetic biopsy of the prostate, which is invasive. We do this as an outpatient procedure now, and most people tolerate it without any issue under local anesthesia itself. Once the biopsy has been done, we evaluate the type of tumor and we stage it into whether it's confined to the prostate or whether it's gone beyond. And Professor Dasgupta will obviously touch upon some treatment options with you. We do scans, we do bone scans, we do PET scans. Bone scans are to see if the cancer has gone to the bones. As you can see in this patient, it has gone to the bones. And PET scans are slightly more detailed scans, CT scans, to see if they've gone to the lymph nodes or beyond in certain situations. And now PET scans are not only being used to diagnose prostate cancer, but also to work with certain agents given during PET scanning to treat advanced prostate cancer. And this is what we come up with, depending on the stage of the prostate cancer, depending on where it is located, if it's spread to the bones and if it's metastatic. So this helps us pick up the type and location of the tumor. So just to conclude the first part of the talk, prostate cancer referrals have dropped off at the minute. We have done a lot of comms in NHS England. This is the newspaper article which has come out of the local press, in which we are encouraging patients to come across who may suspect they have prostate cancer symptoms. So without further ado, I'll hand back over to Peter to carry on with the session. Thank you very much.
Thank you, Nikhil. And we've got Prokar Dasgupta there already, who is going to take us into the next part of the session. So thank you, Nikhil. Prokar, if you can load up any slides. Prokar is, again, I'll say, is a Professor of Surgery at Guy's, Fellow of King's College London, and has been very active with robotic surgery for almost 20 years now, at least. Is that right, Prokar?
Correct.
Good. Welcome to the University of Hertfordshire.
Thank you, Peter. Thank you, Nikhil, and thank you, friends. Can you please hear me and see my slides?
Can hear you, can't see the slides yet.
Okay, I have started sharing, but let me...
Upward arrow.
Upward arrow, share desktop, yeah. Share desktop, yeah, here we are.
Good, can see it, yeah.
You can see me now, yes?
Yes.
And you can hear me loud and clear. Perfect. Thank you so much for this important invitation. I am based south of the River Thames. We are called King's Health Partners. This involves King's College London as the university and 4 hospitals, Guy's, St. Thomas's, King's College Hospital, and South London and Maudsley. And while we are an international organization, we are also very important to our local population. And as some of you will know, we are surrounded by Lambeth and Lewisham, and a lot of my colleagues, and indeed a lot of my local patients, are from the African and Caribbean communities. So like Nikhil, I am fortunately or unfortunately a urologist. My patients often look upon me with a degree of pity and say, is this what you do for a living with your fingers up? Well, someone has to, and hopefully along the way, we can save the lives of a few men. Nikhil has already touched on the very contentious issue of prostate cancer screening. And if I was a patient, I would be so confused by different guidelines from different parts of the world that I thought, well, we should put together a guideline of guidelines in the British Journal of Urology International, of which I have been the editor-in-chief just until 2 months ago, a decade of editorship. So here is what the guidelines really say, and I leave you to make up your mind on that. If you look at randomized trials where you assign patients to either screening or no screening, there's no question that screening will reduce the risk of prostate cancer spreading out of the prostate and going to different parts of the body. When I was training 25 years ago, 3 in 4 of my patients would be exactly that, patients where the cancer had spread, and there was not much you could do to actually save them. Today, I think majority of patients come in because we are trying to find the cancer early, but the flip side of it is that we don't want overdiagnosis, and we certainly do not want to follow overdiagnosis with overtreatment. Several guidelines now actually recommend that if you have a family history of prostate cancer, or you are from an ethnic group where you have a higher chance, that perhaps a single PSA blood test when you turn 40 might be helpful. But then I take you to this beautiful island of Tobago, and we as the British Journal of Urology International were the official journal of the Caribbean Urological Association. And if you look at this, despite being a beautiful island, it has a much higher incidence and prevalence of prostate cancer. Indeed, 17% of men in Tobago will have it. And there is no doubt that they have a higher risk of dying from this disease. So this was a plea by the Tobago Cancer Society to actually start screening for this cancer in their men. Now, when you come to treatment, I just want you to think of treatment in 3 boxes. The first is observing the cancer, as we can do if it is a small cancer or it's a cancer that is not going to cause you much harm. Secondly, taking the cancer out of the body, which you can only do in one way, which is by surgery. And third, leaving the cancer and the prostate inside the body and treat it with a number of different energy sources. So those are the 3 ways I would like you to think about the treatment of prostate cancer. So the first is active monitoring. Notice the word active. This is not about just turning up once in a while and having a PSA blood test. This is actually actively looking after the patient to make sure that the cancer still remains docile and doesn't progress. And I want to highlight some very important information which has literally just last month come out from a consortium called the GAP Consortium. This is 13 centers worldwide. We are one of the centers in this consortium. And I want you to look at this graph. Don't be scared of it. Let me explain this to you. This is the years since the diagnosis of cancer. You see, we have followed up patients for up to 10 years. And this is the proportion of men who need treatment. So here is 50%, this is below 50%, and this is above 50%. And these are men who we have watched for over 10 years. In brown, you will see that of the nearly 10,000 patients, 6% were of African descent. And this is that curve I want you to look at. So as time goes on, more men of African descent needed to switch from being monitored to having some treatment because they had a risk of progression, they had a risk of upgrading, i.e. the cancer becomes more aggressive in the African men than in the Caucasian men. So this is a very, very important message in those who are being monitored, particularly if you are of African descent. And this is absolutely fresh information. So monitoring certainly can be done. Indeed, the benefit is that it creates the same quality of life for you. You don't have any interruption, but it has to be close monitoring, initially every 3 months, then every 6 months, then once a year. And African men will have a higher risk of progression, so they have to be monitored closely. The next, as I said, is surgery. In the old days when I was training, we used to perform this with a cut below the belly button, which was about 6 inches long. But 20 years ago, we really moved to a different form of surgery, which is called robotic surgery. Now, fear not, this is not a robot which just goes crazy and does various things. This is a robot which is controlled by the surgeon. If you see my arrow, the surgeon is seated here with his or her head inside a console, moving these tiny little robotic arms with his own hands and feet. And there is the patient underneath the robot. This is a form of keyhole surgery that we do through 5 or 6 small keyholes. It has a 3D HD camera which magnifies the prostate, which is the size of a chestnut to the size of a football. It also has these tiny little arms which go in through other keyholes. And you will see here that these little wrists are like a human wrist, except they have no tremor. And the wrists are only 7 millimeters in size. I repeat, the wrists are only 7 millimeters in size, much smaller than my hand, which takes a glove size 7.5. So Nikhil and I have really enjoyed doing this kind of surgery because the patients recover quicker, they lose less blood, they have shorter stay in hospital, and I think by and large, they do better. You will notice this graph. I just want you to focus on this part. This is the blue part, and blue stands for robotic surgery. When I started, this blue part 20 years ago was 1%. There were 2 robots in the country at my institution and St. Mary's, which is north of the River Thames. And this really, I was the only guy doing this operation. And today, this is 90% of all prostate cancer operations for removal of the prostate gland in the United Kingdom. So we have gone from 2 robots in 20 years to 80 robots, a complete shift in the way we practice surgery. Why do we need these fine instruments? Nikhil has already shown you this anatomy. This is a man from the side. Here is the prostate gland. This is the bladder which holds urine. This is the sphincter muscle which keeps a man dry. Otherwise, we would all be wet and peeing all the time. And these are the tiny, very fine nerves which run beside the prostate and go to the penis. A man's nightmare because he could lose his erections if we are not careful around these nerves. So having fine instruments, 3D HD vision, no tremor, allows me and surgeons like Nikhil to do a finer job on their patients. But please remember this. Please do not go finding a surgeon with a robot. Find the right surgeon. And I say this repeatedly to my students and to my patients. A fool with a tool is still a fool. So if you have a very experienced surgeon who does the old method of open surgery, and you have a new surgeon who's done 2 operations with a robot, I, as a patient, would go to the more experienced person, because in the end, it is not the tool, but the experience of the surgeon which makes a difference to the patient. So this is a very, very important message that I want to leave you with. What have we been doing in our institution? We have been 3D printing the prostate. So this is a prostate that I removed. I can tell you the cancer is here. The muscle, the sphincter muscle I showed you is here. Literally, this is a millimeter in real terms. We 3D printed his prostate before the operation, took it into the operating room, and it allowed me to very carefully preserve this muscle and preserve the nerves for erections which are on 2 sides of the prostate gland. So today, we feel that 3D printing a prostate or other organs indeed can give us better cancer control, and we leave cancer behind in very, very few patients compared to what we used to before. So this is a new innovation in the field of robotic surgery. This is rather concerning if I told you that robotic surgery causes more regret despite all this high-tech stuff, then you as a patient would be very worried. But believe me when I tell you that this paper came out of the United States, and the colleague who wrote it said, Prokar, this is absolutely true, because my patients felt that they were having high-tech surgery, and some of them actually thought that their erections would be better afterwards compared to what it was before. That clearly is not feasible. So the problem is they were not counseling the patients properly and not managing their expectations. The lesson we learned from this is it's not just the robot, but it is winning the minds of your patients. The way we do it is we counsel them, prepare them, get them fitter, teach them pelvic floor exercises, show them how to recover their erections, manage their expectations of their partners, and then we do the same afterwards and get the best results. So it's not just the technology, it's not just the surgeon, it's the team which looks after the patient and manages their expectations and prepares them for this operation. The other question with robotics is, well, it's very expensive. £2 million kit, not many places can afford it. Yes, we have 80 robots now in the country. Yes, 90% of these operations are now done robotic. But are we perhaps causing financial damage to the NHS? Well, thankfully, 20 years on, I can say hand on heart that we are not. This is a paper which we have literally just published in an important journal along with Harvard Medical School. And this shows for the first time that across all cancers, not just for prostate, but also for bowel cancer, for female cancers, a hysterectomy operation, robotics costs less than open surgery. And the reason for this is because the out-of-pocket costs, i.e. return to work, employment, all the other societal benefits are better with robotics. People are fussed about what happens in hospital, but we are looking after you as patients. We should also be looking at what happens to society, and if you return to work quicker, then you will certainly be of greater benefit to society and save costs. So this is very, very new information, and I'm thankful that 20 years on, we are finally able to say hand on heart that we did not cause any financial stress to the NHS. Robotics, one side, what are the other ways of treating it while leaving the prostate inside? We don't have to remove it in everyone. This is putting seeds in the prostate. This is the prostate gland again. These are radiotherapy seeds, and this is called brachytherapy. Again, some men can have this. It is as good as taking the prostate out completely, and some men who do not want a major surgery will have this. There is something called focal treatment. This is called high intensity focused ultrasound, whereby you can just burn the tumor and leave the rest of the prostate behind. Clearly has advantages in that if you have a single spot of tumor, you can do that and cause less damage to erection. So this is certainly coming to the fore, but for very selected patients. And then you can freeze the prostate by putting these little needles with ice balls like this, which is called cryotherapy. Cryo means freezing. So this is called ice ball treatment with liquid nitrogen. But then not everyone will have localized cancer. Some of them, the cancer will start breaching the capsule, which is the eggshell around the prostate. If you imagine the prostate to be an egg, there's an eggshell. So some of them will have what is called locally advanced cancer. And particularly for the elderly or those who are otherwise unfit, we would treat them with hormones and radiotherapy. What does that mean? We take away the food for the prostate cancer by giving hormone injections to the patient, and then 3 to 6 months on, we would give them radiotherapy. But then the cancer could also get out of the prostate and spread to other parts of the body, like the bones, as Nikhil showed you. And there we would use hormones, which is to take away the food for the cancer, and also combine it with chemotherapy. So this is the prostate cancer continuum. And I think this is good news for the patients, because we have a number of new treatments, a number of new tablets, a number of new chemotherapy agents which we can use to treat cancer, which were not available even 10 years ago. So I think this is a good news message that I have for you. Despite the progression of the cancer, we can treat it. So this is about radiotherapy. On the left is radiotherapy in the old-fashioned way, whereby we would have 3 beams. This is the prostate gland in the middle. This is the rectum. Remember that image that I showed you? This is the rectum just behind. And we would use 3 beam profiles. And today what we do is called intensity modulated radiotherapy, whereby we avoid damage to the rectum and surrounding structures by focusing the radiotherapy only to the prostate. And even better, the latest innovation is to put a little balloon between the prostate and the rectum, a device that is called spacer, to lift the rectum away from the prostate and thus reduce the risk of radiotherapy causing damage to surrounding structures. Once the cancer has spread, as I said, hormones and chemotherapy is standard of care, but there is this new tablet called abiraterone, which has been tested extensively in this trial called the Stampede trial. The Stampede trial is the largest prostate cancer trial in the world. It's a British trial. And what you do is give this tablet, you take 2 tablets along with a steroid, and you have to keep your stomach empty for an hour or 2 before and afterwards. But the new information is, look at this. This is low-fat muesli with a few blueberries. And indeed, what we are now saying is you can take 1/4 of the tablet, 250 milligrams, with low-fat muesli breakfast, and it is equally effective. So even research into how to take these new tablets is ongoing and very, very good for patients. This is another tablet which our oncologists or cancer doctors have been using a lot during the pandemic, which is called enzalutamide or Xtandi. And again, the first paper on this actually came out of London, and this has been very effective during the pandemic when we have been unable to see many of our patients face to face. Finally, just a few thoughts. I've been talking to you about the treatment, which is either watching the cancer carefully or taking it out with robotic surgery, or then using a number of different energy sources to treat the cancer. But what about the mind of the patient? This is, look, just published last week from my group. This shows that we must not underestimate the mental health impact of prostate cancer. And we are giving more and more attention to this for our patients and their partners, because suicidal tendencies can happen in these patients, and we would have failed them if we were just looking after the body and not the mind. So we have what is called a prostate cancer survivorship pathway. All I want you to see is we have a support group and we have education seminars. This is before we treat them. This is the counseling. This is during treatment, and this is after treatment. And we have everyone from specialist nurses, doctors, patients' partners, and even a psychologist in the survivorship pathway. So I think this is a classic example of teamwork to look after the patients like they are our own family. Finally, there was mention of artificial intelligence. We are doing quite a bit of work for this. Look at this. These are the pathology slides. So whenever we take a biopsy, we send it to a pathologist. he or she will put some stains, which are little liquids, and then look at this cancer under a microscope and give it a score. Can a computer do this better than a human being and take away the variation in readings between human beings? Absolutely, it can. I have also been working with a company called Jiva AI. Actually, they come out of what is called the National Clinical Entrepreneurship Program. This is a UK government-wide project. And here is an MRI, which Nikhil showed you before. Here is the cancer. And this machine learning algorithm is 90% accurate and takes away the variation between different MRI experts reading it. Human beings make these kind of errors, but a machine looks at it, and once you train it, it does not make that error. Nothing is 100%, but to me, 90%, if I was a patient, is pretty good. And finally, this is something that came out in the Telegraph just last month. They got very excited about the fact that I was championing something called trustworthy autonomous systems. And the reporter put it to me saying, Professor, 28.4 million surgeries canceled this year due to COVID-19. Could a robot help us do some of this autonomously? And this is the diagram, the cartoon that they drew after my reaction to that. I said to them, look, some parts of an operation in 5-10 years time could be done automatically, whereby you program a robot and it stitches better than a human being. But to tell a patient that I will just have coffee, press a button, and a robot in different rooms will do the job will not be acceptable to most of my patients, and is purely fiction, not science. So again, thank you very much indeed for having me, Peter. I'm really, really grateful to be able to participate in this very important initiative. Thank you.
Thank you, and thanks to both of you. We can invite questions. Just hoping that you might want to unshare your screen now, Prokar.
Yep.
Thank you very much. Thank you. Thank you to both of you. We can invite questions now, but I hope you won't mind if I ask one question to both of you, and maybe you want to debate this between the two of you if you want. And that is, since this is Black History Month, I'm going to ask the obvious question. Tell us why you think, genetically or any other reasons, it is that black people, black men, are more commonly experiencing prostate cancer than other groups.
Nikhil, you want to go first?
You're on mute, Nikhil. Unmute yourself, Nick. That's it.
Thank you very much, Peter and Professor Dasgupta, for a fantastic talk. I think we are yet to know exactly why. Hence, a lot of work is taking place, but this is largely down to genetic factors. A lot of gene profiling has happened. But the important thing to remember is the key message being the chance is 50% higher. And what we don't want to see is, despite a lot of advent of technology, which Professor Dasgupta has discussed, which is taking place, is to find cancer in a form which is curable and treatable. Coming back to your question, it is largely down to genetics, largely down to race-based genetics, and also, more importantly, we are also picking up a lot more cancer than we probably did a few years ago, based on patients coming forward to have their PSAs checked, coming forward to have themselves examined based on a lot of communications which are going out. And Prostate Cancer UK, we've got a big project going on right now to exactly focus as to why Afro-Caribbean patients have a higher risk.
Yeah, Prokar.
Peter, I will answer this in two ways. I completely agree with Nikhil. One is a parallel study whereby you look after a number of patients across populations. So this has happened in the UK. It's called the PROCESS study. We were part of it. Bristol was part of it. So it happened essentially across southern England. And that does show exactly what Nikhil is showing, but does not give the reason for why this is the case. Similar studies I showed you from Tobago, it's absolutely real. Again, does not tell you the reason. So here is my understanding of the reason. You see this pen? Yeah. So the pen, if you imagine the pen to be a chromosome, and we humans are all made of chromosomes, It has a little short arm, yep, and it has a longer arm, which is the tail of the chromosome. And in this are two genes, call them X and Y, but actually one of them is called ERG and the other is called TMPRSS2. And what happens in prostate cancer is TMPRSS2 goes and fuses with this gene. So the two genes get together and fuse across the chromosome. In black men, there is more of this fusion. Yeah? So that is one of the early explanations of why that may be the case. In the 100,000 Genome Project, which was run by the British government, again, people are trying to understand this. There are certain kinds of cancers which occur in different parts of the prostate, which carry the secretions which Nick talked about, the liquid that passes through the prostate. These are called ductal cancers. Do they, for example, happen because of this gene fusion? So this is currently being investigated. But here is another very interesting thing during COVID. Nikhil and I just published a paper in a very important journal where we were using artificial intelligence to see if we can find targets for COVID. COVID, as you know, goes through the nose, and the nose has cells, it has cell linings, and on the surface of the cells is a little lock and key mechanism. So the virus, our invisible enemy, will attach to that lock like a key. This gene fusion, TMPRSS2, that I just mentioned in prostate cancer, just sits underneath the lock. Can you believe it? So we are now trying to find ways of blocking this with various tablets, which we use in prostate cancer. How exciting is that for a challenge that we are facing like never before? So I think those are my two answers to this very important question.
Thank you very much. I'm very conscious. I know that Nikhil's got to move on to another talk. Nikhil, is there anything you'd like to round off with?
No, I'm going to share some of the stuff that I'm doing with Professor Dasgupta, and how our collaboration will be more successful. So I just, I'm happy to go to the next talk, Prof, if you're happy with that.
Okay. Again, thank you so much, Nikhil. An absolute pleasure.
So my next talk is on the latest research taking place at the University of Hertfordshire right now in urology. And I'm really pleased to report that I'm working very closely with Professor Dasgupta on some of these projects, which I'll share with you. So currently, there's a lot of urology research which is taking place. I've been a senior lecturer at the university now for just coming up to 5 years. And the two schools that I've been collaborating with have been predominantly with the School of Life and Medical Sciences at the University of Hertfordshire and the School of Engineering, where we are talking predominantly about enhancing robotic technology, talking about a lot of biomarker work, with the entire aim, as you can see from both the talks from myself and Professor Dasgupta, on focusing to improve cancer patient care. So that's what we focus on. And the first project is to do with robotic surgery versus open surgery. This is something called cytokine-guided surgery. So the principles of open versus robotic surgery are fairly different. In open operations, this is when I make a new bladder for a patient once their bladder has been removed. It's quite a large incision, but the risks are that patients may get a wound infection and they may have a lot of pain afterwards. But what we're doing right now is that we have just published a paper in Current Urology on 10 patients who had robotic prostate cancer surgery, in which we randomized patients between low pressure and high pressure whilst operating, because when a patient has robotic surgery, the tummy needs to be filled up with carbon dioxide. So we randomize the patients between high pressure and low pressure. And we currently have a study going on in which we're looking at bladder cancer patients in whom I'm removing the bladder with a robot, but also making new bladders or a stoma with the robot itself. So we had a successful grant from CONMED. This is on the NIHR portfolio. And we're collaborating with Belgium, Sweden, and Cambridge on the study. And what we have found in 20 patients who were in the initial cytokine-guided program, in which surgeries were done at the Lister Hospital, but the analysis took place at the University of Hertfordshire, was that low pressure certainly has a lot of benefits in the context of patients' recovery. in how quickly they go home, how quickly they open their bowels after the operation. So we are propagating low pressure cytokine surgery. So we have a group of 5 of us working at the School of Medical and Life Sciences at the University of Hertfordshire for the next phase of this exciting study. In 2018, we started off something called a bladder cancer biomarker study with a product called Euro 17 from California. And I'm pleased to report that we are the only center that's at the Lister Hospital where I'm the chief investigator for this product, in which for Europe. And we have just published this paper in the British Journal of Urology Compass. We had funding and grants which came across from the manufacturer. And we did the trial on 150 patients. It's a very important study because what we have found is that the sensitivity of this product is 100% for bladder cancer in the urine. So we are being able to pick up 100% of new tumors in the urine with the Euro 17 product. And this has a very important role to play at the minute because not only will it help enhance diagnosis, but we are also looking into evaluating this for patients whose treatment or surveillance may be slightly delayed due to the ongoing COVID-19 pandemic, who may not want to be coming into the hospital to have their bladders examined regularly to check if their bladder tumors have come back, but purely on the basis of a urine sample. So we are the first center in Europe. We got CE marking for the product, and now we are focusing our attention on patients who've probably been waiting on the backlog with bladder cancer for checks to see if that can be replaced for a period with a urine test, because the sensitivity of this biomarker is 100%, and this is data on 150 patients. The second thing that we tend to do is just like Professor Dasgupta runs a nerve sparing program at his hospital in London, we run a nerve sparing program at the Lister Hospital in Stevenage with my colleagues Jim Adsett and Tim Lane. And we do a lot of nerve spare. We have a lot of people referred, and we've published recently on 200 patients, and now we've just got our paper ready for 500 patients. But the important thing to remember is what we are looking at is robotic haptic feedback, because the robot may have small arms, like Professor Dasgupta mentioned, 7 millimeters, but there's no feedback to the surgeon on the console to see how hard or how soft tissue is. So we've just published a systematic haptic feedback review, and I will be collaborating with Professor Dasgupta's group. I know he does a lot of haptic feedback work next, to see if we can work jointly between the University of Hertfordshire and King's in London to evaluate the improvement of haptic feedback, because this is crucial to improve patient outcomes. And again, an overlap on artificial MRI studies. We have put in application grants at the University of Hertfordshire, looking at AI technology purely for MRI prostate reporting. We've also working at with microfluidics at the University of Hertfordshire. We've just got a grant ready, which we will be submitting. The initial systematic analysis has been is getting prepared. Looking at the development of a biomarker from the point of view of microfluidics, extravesical biomarker in the urine to replace the need for a biopsy in patients. So instead of putting patients through an invasive biopsy, whether a urine test could help. So this is called extravesical systems, which we're working with in the School of Medicine and Life Sciences at the University of Hertfordshire. And this is the paper which Professor Dasgupta mentioned, very exciting paper. You know, AI, cancer, COVID, where does it all fit in? So this is a recent publication which I've just done with Professor Dasgupta. So just to conclude, you know, there's a lot of work taking place at the University of Hertfordshire, 47 successful papers published in the past 3.5 years from our research group. But our focus of attention is patient improvement research. And we hope that, yes, there's a lot of technological advances taking place, but we will continue to endeavor to improve patient care even more. Thank you very much.
Thank you very much indeed. Right, I'm not sure if the chat function is working or not, because I don't know if, but I will invite anyone out there to send in a question or to raise their hand and send in a question. Otherwise, it's going to be me that dominates the conversation. I've already asked one, the obvious one about Black History Month. I'm just interested in the ways in which Prostate Cancer UK supports your work. They are a charity. How important are they for your research work, Prostate Cancer UK, or is it other sources of income that fund your research?
So, Nick, should I take that?
Please, Prof.
So Prostate Cancer UK are the largest charity, Peter, as you know, in this field. Clearly, they have taken a hit, just like Cancer Research UK during the pandemic, but they are vital to us. For example, we have had funding from them for something called Duffy antigen, which is a blood antigen on red blood cells and white blood cells, which we have studied and its relationship to prostate cancer. They have truly supported some of our work on technological developments in prostate cancer, such as energy sources. But in addition to that, there is another charity of which I am a trustee of late, which has been vital to our progression. This is in addition to UKRI and the MRC, because I sit within the Medical Research Council Center at KCL. So that charity is the Prostate Cancer Research Center, and it has funded our work at King's to the tune of over 5 million over 5 years. So we are the Prostate Cancer Research Center for Excellence. This was an open grant call 5 years ago. And in 2014, we established this with a view to looking after things like using your body's own defense mechanism against prostate cancer. Imagine how exciting it would be if we are able to take cells and chemicals within our own bodies. These are called cytokines. They're tiny little proteins, just like the protein milkshakes that we drink, and take these tiny little proteins and make sure they just kill the prostate cancer cell, but do not cause toxic damage around. It's a bit like having your cufflink. If your cufflink stays in place, it's just going to stay there and not fall off. So we use a technology called tailing, whereby this little protein will attach to the prostate cancer cell, kill the cancer, and not cause collateral damage. We have already tested this in animals over the last 5 years and about to go into a very exciting trial in humans, again funded through a charity in addition to the Medical Research Council. So I think Prostate Cancer UK is very important, but there are also other charities who are very important to us.
Okay, thank you. Can I ask, and this is to either of you, tell me, because this is Black History Month and there is the preponderance of diagnosis that fall upon people from Black and minority groups, I'm going to ask a self-interested question now. The larger definition of Black and minority ethnic includes people of Asian origin. Tell me about, all three of us have an interest here. Tell us about people of Asian origin, please.
Nikhil, why don't you go first, and then I will answer that. Yeah.
So it's an interesting question, because if you look at the incidence of prostate cancer in Asia versus population of immigrants who've come across to the Western world, not only in the context of prostate, but in the context of numerous tumor groups, there's definitely an epidemiological change which happens with moving to a different country, with the diet, with the environment, etc. So in Asia, prostate cancer incidence is not as common as it is in the Western world, and this is largely down to probably dietary, environmental factors. You know, there are lots of tumors which are probably not as common as what they are in the Asian subcontinent versus what we have in the Western world. But the risk of probably immigrants who live here for certainly the second generation predominantly may have environmental exposure. So the risk ratio of the tumor still continues to be the 1 in 8 ratio, which is applied to the Asian subgroup right now. But again, you know, we are seeing more and more patients being diagnosed with prostate cancer in all ethnic groups. And this is down to probably patients coming forward due to patient communications from Prostate Cancer UK. You know, it's not uncommon to stop at a service station and see a board saying that, have you had your prostate checked or your PSA checked, or know someone who's got it. So just to keep it simple, you know, instead of, I would say the demographics are different between what we see in Asia, what we see here, but certainly in second generation or third generation immigrants who come across, the ratio increases due to environmental factors, which do make a difference.
Peter, I completely agree with that. Just to add to it, there is an international study which gets data from something called GloboCan. And that shows certainly that in India in particular, the prostate cancer pickup is very, very low. I use the word pickup because if you now see what is happening in the major cities in India like Calcutta, New Delhi, Mumbai, and Chennai, prostate cancer is on the rise. Now, is it that it has suddenly on the rise? Has something magical happened to the diet? Are they eating more burgers rather than vegetarian food? I don't think that's the case. What's happened is the patients in these cities have become more aware because each of these cities now have robots. A few years ago, India had 7 robots. Now it has 70 robots through a charity which I'm part of called the Vatikuti Foundation. So suddenly the men in this city, also pushed by their wives, are going for PSA testing. So the cancer was already there, but we are picking it up more due to awareness. The second thing to say is the people in India who get prostate cancer get much more aggressive cancer. So the numbers are lower, but the cancers are more aggressive. So I typically operate on patients who have locally advanced disease, which has broken out of the capsule. It's very rare to find patients with cancer within the capsule, the eggshell. And finally, what I didn't mention because we are talking in a different context was those graphs I showed you of active monitoring. Just like the African men, the Asian men in that series also did worse. So you have to watch these patients very, very carefully compared to their Caucasian counterparts. You could say, well, it's biased because of the 10,000 majority were Caucasian, but certainly that was a clear finding in 2020 out of watching these patients from 13 centers worldwide.
Now, only because I'm conscious of time, and we've had an hour now, and this recording will be saved and used by people, I'm sure, within the University of Hertfordshire. Can I ask you to just round off with one message that you would like to give about prostate cancer, the future of prostate cancer, and particularly because it's Black History Month for people from Black and minority ethnic backgrounds?
Prof, go ahead first and I'll follow.
My message is very, very simple. Black men are more prone to getting this disease. So there is no point in hiding your head in the sand. Be aware of it. If you have a family history, have what I call smart screening, because if it is picked up earlier, we can do something about it. There are a number of treatments for this. We do not believe in over-treatment or over-diagnosis, but today there are a number of very, very effective treatments which can cure you of the cancer, give you excellent quality of life, and save you for future generations so that you can grow older without the threat of prostate cancer hanging over you. So this is a good time, and I would urge patients from the Black and ethnic minority groups to not ignore prostate cancer and this disease. Thank you.
Thank you, Prokar. Nikhil, anything you'd like to round off with?
And just following on from Professor Dasgupta's message, my message would be ditto. Please come forward, seek help, but don't be afraid to come forward. And what we've seen during the COVID-19 pandemic in certain tumor groups is that there has been a drop in the number of patients coming forward. Obviously, we will see this kind of equalize in the next few months, but prostate cancer certainly has dipped in the number of referrals coming to us. And this is down to phobia to come to a hospital. And the main concern, as Professor Dasgupta said in his talk, that early diagnosis definitely improves the outcomes. So we are open for business. The NHS is open for business. See your GP or call 111. We are available for you. So, do not hold back and come forward if you have symptoms, if you want to have a PSA screen done. Prostate Cancer UK does a lot of research, like Professor Dasgupta explained, but Prostate Cancer UK also has a lot of support services. So there are phone numbers on their website. If someone is in doubt, they can give a nurse specialist a call who can escalate to clinical experts. I do a lot of work for them. So there are ways and means of coming through, but don't stop coming forward, because early diagnosis, early intervention is beneficial than treating advanced disease. And thank you.
No, and I can certainly testify to that. from my own personal experience. What I want to do is to again thank you, not just for this recording, but for everything you're doing and keep on doing. Thank you for being part of Black History Month for the University of Hertfordshire. Thank you both.